Hi, everybody. Thank you for signing in early. Feel free to take a minute, get some coffee, some lunch if you haven't had it yet. We're going to get started on time today in about 6 or 7 minutes. So hang tight. We'll be right back. Welcome, everybody. It is good to see so many people joining us today. Hang tight. We're going to get ready in just about 3 minutes. So please feel free to grab a cup of coffee and get settled in. We'll be right back with you. Okay, everybody, it is 1 o'clock. We are going to go ahead and dive in. I have a few pieces of just general information up front, and then I'm going to pass it over to Justin Gaines, let him introduce himself to you and get started on the presentation. A couple of just housekeeping things. We are recording this webinar. We will be sending out that recording along with these slides in the next 48 hours. And so please don't feel like you have to take hazardous notes throughout the whole thing. If you just want to really enjoy and begin to soak in the information, you will be getting the slides and the recording, especially if you want to share that with any colleagues. So that's number one. Number two, we do have everybody on mute. And that is because we had hundreds of providers register for this webinar, and we want to make sure that we get through the information. We did leave time at the end for Q&A. And so please, if you have a question that you would like answered, in your toolbar at the bottom of your screen, you're going to see a Q&A box. Click on Q&A. That's where you can drop in your questions. They will be documented and given to us behind the scenes. We will try to answer as many as we can today in the allotted time we have. If by chance we do not get to your question, no problem. What we'll do is follow up in that same email that we're sending the recording and the slides in. We'll follow up with a document that answers your questions or contact you directly to make sure that your question is answered. And so please drop them in the Q&A box, not in the chat. This is how we will make sure that we have every question and we can answer everybody's information as needed. And one last thing that I have, this is an interactive webinar. We have a few polls throughout. We would appreciate your participation in those polls. They really help us just understand what your pain points are and where you're at with your in-house billing, and just help us know what best to cover for you. So please participate in those polls as we go through this webinar. But right now, we're going to go ahead and get started. I'm going to pass it over to Justin Gaines. He is Vice President here at Symmetry Behavioral Health, and we really want to, have plenty of time to get through the data. And again, Q&A at the very end. So please drop in those questions as you have them. Justin, I'm going to go ahead and pass it over to you.
All right. Thank you so much, Renee, and appreciate everybody taking the time out of their day here to join our webinar. As Renee mentioned, we want to make this interactive. We want to make this educational. We want everybody to learn something here and take away from our webinar. And as mentioned before, if you have questions, please drop them in the Q&A, respond to those poll questions as they come up. And if there's anything that we can't answer, we'll make sure to get back with you after this meeting and this webinar to make sure we have everything addressed. I'm really excited to be here. Behavioral health billing is something that's really close to me. I've been in behavioral health billing and credentialing since 2016, doing everything that goes into making a billing or a revenue cycle successful. And so I'm looking forward here to going through this presentation and helping share some of my knowledge with you. The title of this webinar is Behavioral Health Billing 101. So we are going to get pretty basic in some areas. So there may be some concepts or some terms that you're already familiar with. And there may be some new things that are, just coming to you for the first time. And then some stuff in between. So as we go through this, hopefully you're able to see things that are familiar to you, as well as some other concepts that could help you make sure that you have a regular and successful billing cycle as you manage your practice or your organization or whatever the case may be. So as we go forward here, let's take a look at the agenda and what we're going to discuss here on today's webinar. Welcome and introduction. We're going to go through what our learning objectives are for today's webinar. We're going to cover some key terms, some terms that come up in day-to-day when it comes to billing and revenue cycle management. This way we all have a kind of foundational understanding of what that means. Then we're going to define the revenue cycle. What does revenue cycle management mean? And how does it affect your practice, your organization on a day-to-day basis? And then we're going to go even more into detail in what I like to refer to as the 4 pillars of billing, and how each of those pillars, if managed correctly, will ensure that you have a successful revenue cycle for your practice or organization. Then we're going to cover credentialing, which is different from billing, but obviously a critical component of making sure that you have a successfully managed revenue cycle and insurance for your practice. We'll talk about some quality assurance methods for you to manage yourself on your own, some recommendations for path to success. And then we'll get to the end for some Q&A and really an open forum where we can just talk about anything that's on your mind or anything that's come up along the way. So let's see what our learning objectives are. So we want to discuss what are the key areas to consider in behavioral revenue cycle management. And spoiler alert, there are quite a few of them. The billing cycle, I'm sure as everybody on this webinar knows, is not black and white. There's lots of gray areas and lots of things to consider. So we want to cover as many of those today as we go through this webinar. We're also going to cover the key components of the revenue cycle and best practices to make sure that your revenue cycle, your billing is successful. And then lastly, one of the key things that we want you to take away is how your organization, your practice, or if you're just an individual doing this on your own, how you can be successful in managing your revenue cycle on a day-to-day basis. So those are our key learning objectives today. We'll obviously go through a lot more, but we're really trying to cover those three things as our primary takeaways. But before we really dive in, let's just go through some key terms here and things that come up on a day-to-day basis when you're dealing with billing. So I'm just going to go down the list here. Some of these I'm sure everyone's aware of. So the first one is your allowable or your contracted rate, right? This is the rate that the insurance has designated for your service. And I just pulled out one common procedure code, the 90837. That's your 60 minutes of one-on-one psychotherapy. That predetermined rate will be set. That will be in your contract, and that is your total reimbursement, both insurance payment as well as what your patients owe you for your services. So it's key to knowing what your allowable and contracted rates are. And then when you get into the specifics of each individual plan, you're going to have patients who have deductibles. And what is a deductible? It's just a fixed amount that your patient must pay out of pocket before insurance pays anything. You might have a deductible that's as small as $200 or as large as $8,000 and everywhere in between. And the key thing to remember about deductibles is that if there is a deductible that applies, your insurance is not going to pay anything until that deductible is met. Then when that deductible is met, your patient may still have a responsibility in the form of a copay. That is a fixed amount that they're going to owe you each session, which when you combine that with the insurance payment will yield the total reimbursement or that allowable or contracted rate. It could be a $20 copay, a $10 copay. It really depends on the specific insurance plan and also the service that you're offering for your patient. The other component that your patient might owe is coinsurance. And coinsurance is a percentage of the rate for your service. And that amount, that percentage is what your patient will owe. So let's use nice round numbers. Let's say the rate for your service is $100 and your patient owes 20% coinsurance. Well, that means that they're going to owe you $20 per each session, and then the insurance will pay the rest. So coinsurance is a percentage of the rate. So it's important to know what that rate is, that contracted rate, in order to calculate the coinsurance. Your out-of-pocket maximum, that's what the total amount is that the patient can pay out of pocket before they don't owe anything else. So after they hit that maximum, which is usually a cap, could be $5,000, $7,000, $8,000. From that point forward, insurance will pay 100% of the allowable contracted rate. We tend to see patients, if they are going to hit that out-of-pocket maximum, do that later in the year after they've accumulated healthcare expenses throughout the year. And it's not just necessarily for behavioral health expenses. They could have other medical expenses that they're incurring, which all add up to the out-of-pocket maximum. But once they hit that cap and they exceed it, insurance is going to pay everything. So those are the key terms as it relates to what you're going to collect and what you're going to see on a day-to-day basis as it comes to the different patient policies, the different insurance policies that your patients have. So let's talk about some billing terminology that comes up. If you could just jump back to the last page, Renee, just 2 points at the bottom there. So we have rejections, we have denials. You often hear those in a lot of cases, and sometimes you hear people talk about them interchangeably, but they are distinct as far as what they are. So let's go through each one. A rejection is when a claim has been submitted to an insurance company, but the insurance company cannot process it because there's some type of error on the claim. Maybe the date of birth is wrong. Maybe the member ID is wrong. Maybe the address is wrong. Maybe we're billing to the wrong insurance. And in that case, the insurance is going to reject it. They're going to kick it back, and we're going to have to fix that claim so it can be resubmitted. That's different from a denial, which is when the insurance company has accepted the claim into their processing system, but they have denied payment on it. And they could deny payment for a variety of reasons. Maybe the diagnosis code on the claim is non-reimbursable. Maybe the policy is no longer active. There's very many reasons why a claim could be denied. And that reason will come back with that denial. And we'll talk a little bit about how to manage denials and rejections later on. But it's important to make sure you understand what that denial reason is so you can have effective follow-up. As we jump to the next slide here, covering some more key terms as we deal with insurance, we have two different types of plans. We have an HMO, a health maintenance organization. I'm not going to go into the details on this, except just to know that you must be in network with an HMO to be reimbursed by it. If you're not in network, that claim is going to be denied, saying that you're a non-participating provider. No out-of-network benefits for HMOs in nearly all cases. That's different from a PPO, which is an insurance plan that often has out-of-network benefits. So if you're not in network with that plan, you can submit that claim, and it's possible that you could get reimbursed depending on what the in-network and out-of-network benefits are. And oftentimes you'll see on the front of the insurance card, it'll say HMO or PPO. And if you see HMO, that could be a red flag to say, hey, maybe I need to do some additional diligence on this plan, some additional research to make sure that I can accept this insurance plan and bill and be reimbursed for the services. You know, we want to avoid those situations where we find out after 5, 6, 8 sessions that we're not getting reimbursed. And now you have to have that conversation with the patient about collecting. Those are not always the most comfortable conversations to have. So HMO, PPO, important to know. And then when we get into the world of Medicaid and Medicare, we talk about Medicaid managed care plans. And what that is a private commercial company that's contracted with your state's Medicaid plan to offer Medicaid benefits to recipients. And you have to be in network with those plans. So it acts like an HMO. And it's important when you're doing the verification, and we'll talk about verifications in a minute, that you are able to identify what is the active Medicaid managed care plan that this patient has. You don't want to be billing to a plan that you're not in network with. Again, that claim is going to get denied, and it could be difficult to get reimbursed. That's Medicaid. Then we get into Medicare. Remember the difference, Medicare for seniors and certain individuals with disabilities. We have a part of Medicare. Medicare is broken into 4 parts. And the part that we're talking about here is Part C. This is non-traditional Medicare, also known as Medicare Advantage or replacement plans. And this part of Medicare, as it's known, is where coverage is offered through private commercial companies. And popular ones that we see out there are the United Healthcare AARP plan, the Humana Gold HMO plan. These are where Medicare beneficiaries are receiving their health benefits through these Medicare Advantage plans. And again, with Medicare, similar to Medicaid, it's very important to know where the actual coverage is coming from. Because if we bill to the wrong plan or even the wrong part of Medicare, we could see that claim get denied and have a difficult time getting reimbursed. Then just some other, last concepts to cover here that come into play a lot when we talk about behavioral health billing. Secondary insurances. This is where a patient will have 2 insurances. We see this very commonly with Medicare plans. And a secondary insurance policy may process whatever the patient responsibility is, a copay, a co-insurance, or a deductible, after the primary policy processes the claim first. So it has to go in order. There's an order of operations to billing primary and secondary. First, you submit the claim to the primary. Once it's processed and you get an EOB back, then you send that EOB and the claim off to the secondary. And if the claim and the EOB meet the criteria of the secondary insurance payer, that secondary may cover all or part of that patient responsibility. If they do not, then the patient will be responsible for what they owe, unless it's Medicaid. But we'll talk a little bit more about that later. And then lastly, I bring up mental health carve-outs because these are very common. You have third-party companies that process mental health benefits and claims for insurance companies. A very common one is Magellan as a third party. You may also have heard of Carelon, formerly Beacon Health Options. And this is where an insurer uses a third party to cover their mental health benefits and claims. And the key thing is with these mental health carve-outs, it's an HMO. You've got to be in network with that mental health carve-out to get reimbursed for those claims. So all of these concepts here are things that we deal with on a day-to-day basis when it comes to billing for mental health and behavioral health. It's important to know these things, and it's important to know them well, so this way you have a successful revenue cycle. So now that we've covered some of the basics and we have some foundational knowledge here, let's move on a little bit into the revenue. But before we do that, I think we're going to have a poll here. So Renee, what is our poll that we have?
Hey, thanks, Justin. We are asking, do you do your own billing in-house or do you outsource it to a third-party vendor? We're just curious on what the ratio is of organizations that have joined us today. So if you would answer that real quick, that would be amazing. Looks like predominantly we have people that do it in-house. About 65% of you are in-house and 35% of you are outsourcing it. That's where we're at right now. I'll give about 5 more seconds. We moved up to 68% in-house and 32% of you have outsourced it. It's just good to get a feel of who's in the room. So thank you for answering that. I'm going to end this poll now. And again, we ended up as a finale number 69% of you do it in-house and 31% of you are outsourcing it. And so that's our poll. Thank you for taking that poll for us and letting us know. We're going to go ahead and move on. Back to you, Justin.
Perfect. And thanks you everyone for participating in that poll. I think we'll have a few more as we go on here through the webinar. So the revenue cycle. Let's talk about what this is. Let's define it. And you've often heard the term medical billing, I'm sure. That's maybe a legacy term. As we look at medical billing now, we think about it more as the revenue cycle, because the insurance payments that you're collecting, as well as your patient payments, that is your revenue for your practice. And so we need to make sure that we're managing it effectively. And as you can see here from our graphic on the screen, there are a lot of components of the revenue cycle. Each one is independent of the other, but they all are interconnected. And so if one has a deficiency, it could lead to a deficiency in another. And we'll talk more about what that looks like later on. But when we're talking about the revenue cycle, we're just talking about the ability to capture, manage, and collect all of the revenue that's coming from the services that you perform. So we talked about that allowable or that contracted rate. That's the maximum amount that you can collect for an insurance claim. The revenue cycle is the process by collecting 100% of that allowable rate. And it may be 100% from the patient. It may be 100% from insurance or some breakdown in between. But our goal as part of having a well-managed revenue cycle is to collect everything that we can so we leave very little dollars on the table from the insurance claims that we are submitting for the patients that we're seeing. And as I mentioned before, the process flows go into and affect one another. So verifying benefits directly affects whether a claim is going to be rejected or denied. It's also going to affect when you post payments, how you're reconciling those claims as they're coming back from insurance companies. So all of the inputs into the revenue cycle are connected in some way. But when they're done correctly, you can have a very, very effective revenue cycle. So that's what we're looking at here. Obviously, there's a lot of components. We're going to go through 4 of these here to talk about what I like to refer to as the 4 key pillars of billing, to make sure that we have an effective revenue cycle. So as we jump to the next slide here and we talk about the pillars, we're going to go from left to right. We've got VOBs and eligibility checks. VOBs meaning verification of benefits. We've got claim submission. We've got denial, rejection, follow-up, and we got payment posting. There is obviously so much more that goes into the revenue cycle. We just saw the graphic on the previous slide that shows that. But generally speaking, everything kind of rolls up into one of these 4 pillars. And each of these pillars has their own inputs and own components that are important to be aware of in order for them to be successful. So let's talk about each one of them. So the first one is verification of benefits, eligibility checks. I think this is the most important part of the billing process, or at least one of 2. This is really important because it's going to allow you to identify what type of insurance plan your patient has, as in an HMO or PPO. It's going to allow you to get confirm an estimate of patient costs. And I always say estimate because we don't truly know what that patient cost will be 100% until we get the claim back via an EOB, right? So we'll talk about that later on in EOB and explanation of benefits when we get to the posting section. And then likewise, we just want to make sure that we're able to tell the patient, yes, I can see you, and your responsibility is going to be $20 per session. That's going to be a much better patient experience for your clients, for your patients. If you're able to deliver that information on the front end, as opposed to later on, when they may be surprised with a large balance, because who likes that? I know I don't, and I don't think anybody that's seeking treatment does either. So how do you verify benefits? Well, there's a few ways to do that. You could do it through provider portals. Think of Availity, think of Navinet, think of the United Healthcare Link portal. So many insurance companies out there, so many portals, and doing that verification through your provider portal is a great way to make sure that you're getting all of this information. A lot of the EHRs that we use in behavioral health billing also offer the ability to verify patient benefits. So you could do that through your EHR. There may be a cost associated with that. And if there is, it might be a small cost, but you can do that through a lot of EHRs and verify your patient benefits that way. And then the last way to do it, probably the one we want to avoid, if at all costs, is by getting on the phone and calling the insurance company directly. But that has a lot of pitfalls. So if we can avoid that, that's always the best thing to do. So in order, I would say provider portals, EHR, and then calling insurance company directly as a last resort. I mentioned about confirming the estimated patient cost. That's going to be a deductible. That's going to be a copay. That's going to be coinsurance that you can provide to your patient on the front end. This way, there's no surprises later on. As well as you also can confirm the type of specific insurance plan. We talked about the Medicaid managed care plans, and we talked about the HMOs. This is the point in time where you can confirm what type of plan your patient has. So this way, if there's going to be something that prevents you from getting paid, you find that out in the beginning as opposed to later on, as well as other relevant details that might come into play. If there's authorizations that are required, though what we see for mental health and behavioral health is that we don't typically have authorizations. Not to say that there's never authorizations, but typically we don't have authorizations, as well as any exclusions or anything else that's unique about your patient's insurance that might prevent you from getting paid. Where we want to get to is we want to get to an accurate estimate of patient costs, as well as confirmation and certainty that we will get reimbursed for our services. And just some best practices when it comes to eligibility checks: collect your patient's insurance cards, get copies front and back. And sometimes we see cards that are like taken through pictures on phones and things like that. You want to have a clear picture, as clear as possible as picture as you can get, because there's going to be information on both the front and back of that card that's going to be highly relevant for billing purposes. And if we have that information, it's going to make the follow-up that much easier. And then lastly, if authorization is necessary, make sure to obtain that prior to your commencement of services. I'm sure everyone has heard of retroactive authorizations. Those are really, really difficult to get, and insurance companies do not like to provide those retroactive authorizations. So if you do need an authorization, get that authorization up front, know what the start date is. This way you can start treating from that date and you don't have issues getting any previous claims paid or reimbursed. So that's a key pillar of verification of benefits. Very important to the revenue cycle. Let's talk about the next pillar, claim submission. This one is pretty simple, pretty straightforward, but it's so important to the billing process. We need to submit claims timely to ensure they're received by each insurance company according to the timely filing requirements. And every insurance company has a different timely filing deadline. You've got Anthem, Blue Cross Blue Shield, which only allows you 90 days to submit your claims. And that's 90 days from the date of service. So we've got to get those claims submitted quickly. And certain EHRs out there, if you're using them, allow you to submit claims right away electronically. That's great. Get those claims submitted. Other methods, if you're filling out a census or a billing report that you send in or anything like that, that's another way to submit claims. But the key thing here is we want to submit claims timely. We don't want claims to linger, because if we submit them after that timely filing deadline, it's going to be very, very challenging to get those claims paid. I mentioned about using an EHR to submit claims. Often easy to get those claims processed and submitted. So go ahead and do that. Make sure to get those claims in. We want to make sure also that the demographic information is accurate on the claim. That prevents rejections. That's all the date of birth and the address and all the patient-specific information that you'll get on the front end during the intake process, making sure that's accurate so we avoid rejections and unpaid claims. The coding aspect, depending on the type of service that you're offering, you may be billing the same 5 to 7 CPT codes. But it's important to know those codes. It's important to know what your reimbursement rates are. Are there modifiers that are necessary for your claims? Depending on the state that you're in and the insurance that you're billing to, that answer might be yes. And if you're using telehealth, the answer is almost always yes. As well as the place of service, we're going to have unique place of service codes for telehealth, office, patient's residence. all different kinds of places of service where our services could be offered. It's important to know what those things are. So this way you have an accurate revenue cycle when it comes to claim submission. And then lastly, we talked about secondary insurances in the key terms section. This is where secondary claim submission falls under the pillar. And it's really important that we get those claims submitted to secondary. One, just to make sure that we're ahead of any timely filing deadlines, but two, to make sure that we're collecting the maximum amount. So when it comes to claim submission, all of these components are important, including secondary billing, which could be a little bit challenging, but still an important thing to get done. Let's talk about the third pillar, and that's rejection and denial follow-up. Making sure that we resolve these rejection and denials, we mitigate their impact and their risk so we can collect the maximum amount. So how do we do this? We want to identify these issues quickly. Okay, we can identify denials and rejections either as they're sent back from the insurance companies in your EHR potentially, or through a portal, or via a document you might receive, or through an ERA. But it's important to identify these issues quickly so you don't have unpaid sessions accumulate. These issues can be identified through the reconciliation process. We talked about EOBs a bit. We'll talk about reconciliation in just a moment. But as these claims are being processed, they're going to come back to you with a denial reason if the claim is denied. And when we talk about rejections and denials, there's a different timeline for when we're going to see those issues. So rejections, we often see those come back from the insurance companies within a couple of days after we submit claims, so relatively quickly. Denials could take a little bit longer. It could take a few weeks before we see that denial come back. So rejections, we could jump on right away. Hopefully we can get that fixed. We put a B in the patient ID number instead of an 8. Simple things that we can just update and get those claims resubmitted. Denials, we might have to do a little bit more work to find out exactly why that claim was denied in order to get that paid. And then when we look at denials, I always think of denials in two ways. Are they structural issues or are they more targeted issues? So what's the difference? A structural issue is something that's preventing all of your claims from getting paid by a specific insurer. Maybe your claim needs a modifier. Maybe there's a taxonomy code that you're billing on your claim that's wrong, and as a result, all of your claims are getting denied for a particular insurer. Well, when we fix that problem, the floodgates are going to open. You're going to resubmit all your claims, and all those claims are now going to get paid. Those are your structural issues when it comes to denials. Your targeted issues, those are going to be more patient specific. The coverage is terminated. There's a coordination of benefits issue. The diagnosis code needs to be updated. So understanding, is it a larger, more global or structural issue that's causing denials, or is it more targeted to help make sure that you have the most effective revenue cycle for your practice and organization? As I mentioned, certain denials, rejections can be resolved quickly. Others take longer. You might have to get your patient involved. They may have to get on the phone with the insurance company to resolve a coordination of benefits issue. If that issue persists, then you might be submitting claims that will continue to get denied, which then may result in a large patient balance. So being able to resolve denials quickly is important to prevent them from really accumulating. And if you can resolve them quickly through updating something on the demographics or a diagnosis code or anything like that, that's great. Get that claim resubmitted, because we don't want to run into any timely filing issues. Just like with claim submission, we could have timely filing issues on the initial submission of a claim. We could also have timely filing issues when it comes to denials and rejections. We need to get those claims back in correctly. And the only way to do that is to make sure that we have effective follow-up on the denial and rejection part of the process. And then we'll jump to the last pillar here of billing, payment posting. There's a variety of ways to do this, but making sure that your payments are reconciled timely. Anytime you receive a check, a virtual credit card, or direct deposit, there will be an EOB that accompanies that payment. Let's get that EOB entered into your EHR, if you're using a spreadsheet to track it, whatever the case is. This way we can look at aging and figure out what claims are actually outstanding over time, right? And then we can make sure that we're collecting the maximum amount from our insurance claims. When we post insurance payments, you'll have an adjustment. This is the difference between what you charge on a claim and what that contracted rate is. So just to use some nice round numbers, if you charge $150 on your claim and your contracted rate is $100, that $50 difference is the adjustment. That gets written off of the claim, that cannot be collected, and we move on to the next one. So making sure that those adjustments are applied are important, because that's going to allow for the proper reconciliation of your claims. And while you're reconciling claims, we can make sure that our patient balances are updated. So if our patients owe us anything, we're able to collect 100%, or we're able to provide the patient certainty so they know exactly what they can owe. And if they can't pay the whole thing at once, maybe they could set up a payment plan or something else. So you make sure that you're collecting the full amount. And then lastly, this is just the best practice, something I always recommend when the month is completed. We're coming to the end of February here. You take your bank account, you take your payments received through your EOBs, whether it's in your EHR or a spreadsheet, and just do a cross reconciliation against what's in your bank and in your EHR or your spreadsheet. This ensures that you collect everything that's being paid, because checks get lost in the mail, virtual cards get lost in the mail. You want to make sure you're collecting all the money that's being paid to you, and doing a month-end reconciliation with your bank statement is the way to do that. So those are the 4 pillars of billing. Again, everything generally rolls up, but if we focus on those 4 pillars and we have good processes around them, we'll make sure we're having the best revenue cycle that we can. Let's talk about credentialing real quick, credentialing and contracting. So credentialing, key component that makes sure that we are going to be able to treat and bill for the patients that we're seeing. We can credential as an individual, we can credential as a group or facility, all to make sure that we're in network. Credentialing process can take time. The average timeline is around 90 to 120 days. You have to make sure that you're following up with each insurer, so you're getting status updates to make sure to keep the line moving. So this way you or any providers that are part of your organization are credentialed so they can start seeing patients on an in-network basis. And then the second part is contracting. And that's where we get a contract for our organization if we're billing under an LLC or a PLLC. So our organization is able to bill and be reimbursed, and all of our providers are linked underneath that contract as part of the organization. So the contracting part is a critical component. First, you go through credentialing, then you go through contracting, and just to make sure that we have the most updated and accurate contract, that'll have our effective date, that'll have our rates on it most likely, and it will make sure that we have the proper documentation to show that we are in network and are able to get paid for the services that we are performing. And then lastly here, with payer setups, there's a few things that go into it. I like to think of this as the 3 E's of billing: EDI, ERA, and EFT. So EDI, that's the ability to submit claims electronically through your clearinghouse, through your EHR. ERA is the ability to get your EOBs back, your electronic remittances back to your EHR. And EFT is direct deposit. If you have all of these E's, the EDI, the ERA, and the EFT set up, it's going to allow you to have a much more effective revenue cycle. So this is an important component, not something to be overlooked. Credentialing, contracting, and payer setups, all going towards making sure we have the best and most effective revenue cycle possible. So let's quickly jump to some quality assurance methods. But before we do that, looks like we have another poll.
Thanks again, Justin. I want to ask everybody, if you're doing billing in-house, these are for the 69% of you that are doing billing in-house. We want to know, how many hours are you spending on that? It's really important that as a provider, you are gauging where you're spending your time, which is going to give you the most success in your practice overall. And so just curious, for those of you attending today, how many hours are you putting into this? I see we have a big percentage of you right now spending more than 10 hours a week, which is just overwhelming in my eyes, to have to dedicate that much time to billing, but it's understandable. Absolutely. It's a very complicated process. So it looks like, I'm going to bring this to an end. Hold on. I still got a couple answers coming in. If you're in-house, how many hours a week are you spending on your billing? All right, I'm going to go ahead and end the poll and just share the results so that you all can see the results. So we have about 58% of you that are doing it in-house are spending more than 10 hours, 29% between 5 and 10 hours, and 13% of you less than 5 hours. Good for you. And so I will go ahead and send it back over to you, Justin. Thanks everybody for participating in our poll.
It's really interesting to see those stats, because billing can be complex. And in the world that we live in with insurance and Medicaid and Medicare and crossovers and secondary insurance, it's only getting more complex as time goes by. And when I have conversation with folks that are thinking about potentially outsourcing their billing using a service like Symmetry, one of the questions I always ask is, what's the opportunity cost of you getting that time back that you're currently doing on your billing, that you could focus that on your patients, on your practice, or on your other priorities? So certainly as you go forward, something to think about. But our time is valuable, and we certainly want to make sure that we are directing it in the most effective way for our organization. With that being said, let's quickly talk about some quality assurance and things to think about as you're evaluating your revenue cycle. And every revenue cycle has an impact on the organization. And there's really 5 that we look at. There's a financial impact, a compliance, a quality, a productivity, and an EHR practice management impact. So when it comes to financial, are you collecting the maximum amount from insurance claims? Or do you look at your aging report and want to pull your hair out because the numbers are just getting so large that you are just unsure of what way to go, right? That's the first thing to think. We want to see that AR report low and that collection rate high, collecting the maximum amount from our insurance claims. And if that AR report shows a lot of open balances, is it because those claims are actually denied and that's money that's outstanding? Or is it because that we need to document in your EHR or on your AR report that those claims are paid and we could clean that AR report up? So those are things that we deal with quite a lot when it comes to AR reports. Is the claim paid? We just need to document it, or is it actually outstanding and there's money out there that we have to go collect? So the financial impact, always important to consider. The compliance impact as well. We got to make sure that our documentation, your clinical documentation reflects the services that are being provided and billed. We don't want to upcode our services. We want to bill for the amount of time that we're spending. We want to bill for the services that we're offering. That's a critical compliance component that will come into effect if there's ever an audit from insurance companies, but just to make sure that it's a best practice for you and your organization, that the documentation reflects what you're billing on your claims. And then today, there's a lot in terms of changes to payers and regulatory rules that we all need to be aware of. Making sure that we understand what those are and making sure that we are aware of those changes is only going to help us have a more effective revenue cycle for our organization. On the quality impact, we talked about timely claim submission earlier. That can lead to a better patient experience because the faster you submit your claims, the faster you'll get the processing back from the insurance company. So if there's a change in patient responsibility or an issue with the claim, let's find out about that right away, as opposed to months down the road. Months down the road is not going to lead to such a great patient experience, but if it's earlier on, it will be much more manageable. That also gives us the ability to identify those problematic claims before they become issues. That's going to lead to greater collection rates if we're able to identify those issues early. And then if you're part of a large group, you might have a sound billing system in place. There might be better experience that's there, but it's still always important for you to know exactly what's going on with your billing and your patients, because these are your finances. This is your revenue cycle. And it's always good to make sure that you have an understanding of what is going on, even if you're part of an organization that has a billing cycle that's already in place. If we talk about on the next slide here, productivity, what are we talking about here? We're talking about tracking and reporting. Very important. And with mental and behavioral health providers in particular, you're seeing a lot of patients. You could be seeing 30, 40 patients a week, and you've got your documentation requirement, and you've got people calling, looking to schedule. Maybe you have clinicians that are part of your organization and other responsibilities. The reporting can allow you to look at and say, oh, okay, well, this claim is outstanding. These payments have come in. Here's the denials and rejections. Let me go out and resolve these. And that just helps to make sure that you're maximizing your productivity. And then there's a whole bunch of key metrics that you can have associated with your revenue cycle. Clean claims is one that comes to mind. That is, how many claims are you submitting to your insurance companies that do not encounter a rejection? That rate should be 97%. So if you submit 100 claims to the insurance company and there's more than 3 claims that get rejected, maybe there's some aspects of the revenue cycle that can be improved. There's lots of other metrics that are out there, and certainly factoring those in can increase your productivity. And then lastly, with EHRs, practice management software, that just helps with your documentation quality. It helps to manage your revenue cycle. It can help with your reporting and just lead to better and more effective results over time. Let's move on here to the next slide. Just some questions to think about. Are we capturing and billing all the services provided? Are we collecting the correct amounts? Are we maximizing the features in the EHR that can improve the efficiency of our revenue cycle? Are we communicating effectively with our front-end staff, with our billing team, with our clinicians to make sure we have seamless and transparent communication? And do we have effective management and operational reports? All things that will help us make sure from a quality, a productivity, a compliance, and a financial standpoint, we are maximizing the effectiveness of our revenue cycle. As we jump to the next slide here, there's various aspects of the revenue cycle that can lead to leakage, right? These are the errors that we see. It could be credentialing. It could be we're not verifying insurance. It could just be general billing errors. Lots of different things that could lead to our revenue cycle not being as efficient as it could be. These go back to the structural versus targeted issues I talked about earlier. But if you're able to identify, oh, you know what? I have a deficiency in my insurance verification process. Well, let me get that fixed. Now my percentages are jumping. My collection percentages are jumping. My clean claims rate is going up. All of that's going to lead to a more effective revenue cycle over time. So going through these leakage points, and there might be something that's affecting your revenue cycle that's not on here, but identifying a process for eliminating that, or at least minimizing it, is going to go such a long way to make sure that you're collecting the maximum amount and you're maximizing your revenue cycle. So as we continue on here, the path to success, really, we have to think critically about our revenue cycle. I've always said that when you're billing, you have to have good critical thinking and good problem-solving skills. You're going to have lots of information that comes at you from insurance company, lots of words that don't make sense, things that seem to conflict with each other. That's normal. We're dealing with insurance. It's almost like they set it up this way to make it more difficult for us. But if we think critically about how we're doing our billing, how we're doing our revenue cycle, it will just make sure that we have the most effective and most efficient revenue cycle manageable. Having processes in place, knowing what the risk and pain points are, and having quality assurance methods as part of your revenue cycle is going to go such a long way to making sure that you have a successful revenue cycle. And this next one I love, ask questions. Billing is hard. It's not easy. It's complex. And there's lots of great tools out there that could provide you answers. There's ChatGPT, there's Facebook groups, and there's companies like ours, Symmetry, that can help make sure that your revenue cycle is as effective as possible. Insurance world is complex. The more questions we ask, the more information we will have and the better educated we will be, thereby maximizing our revenue cycle. And then also let's identify benchmarks. Like I talked about the 97% clean claims rate. Are we hitting that number? Are we seeing more claims denied than what should be according to the industry benchmark? Understanding what those are and how we can mitigate them or improve on them is only going to increase our performance. And let's look at our performance over time. Are we doing better in January, February of 2025 than we did in January, February of 2024? What was our most challenging month from 2024 that impacted our revenue from billing? And let's figure out what went wrong and how we can improve on that in the future. So learning from the past can help us improve on the future, and understanding what those industry benchmarks are can really help making sure that we have the most effective revenue cycle. And then lastly, everyone in your organization is going to contribute to a successful revenue cycle. Even if you're a solo provider, everything that you do is going to contribute to a successful revenue cycle. If you work with a third-party partner like Symmetry, we are going to contribute to your revenue cycle. And so having just seamless contact, communication, transparency is all going to make sure you're collecting the maximum amount and minimizing the headaches that you get from billing. So I'm going to pause here. I think we've got our last poll and some time to open it up for Q&A. Renee, I'm going to kick it over to you for the poll.
Thanks again, Justin. We are asking attendees, just in case you're feeling a little bit overwhelmed, to please share with us if you would like a free consultation from the team at Symmetry. Our billing experts are happy to spend some time with you. They'll do some interviews and ask questions, take a look, and give you a free recommendations report. No obligation there. Just want to be able to be helpful and continue being helpful if you need it. We will also be looking to do a potential part 2 of this series to continue digging in. So stay tuned for that. If you were registered for this webinar, you will. We have multiple questions that came in, Justin, and so I want to dive into those. I'm going to leave this poll open for just a few more minutes, but we can go ahead and get started on some questions that were asked so that we can get through them all. Very first question that came in, these are being done on a first come, first served basis, and so I hope that we can get through them all. William sent in the question, we are a chemical dependency facility. My understanding is that there is nothing we do that Medicare will reimburse. Is this true?
Yeah, so it's a great question. And the way that I would answer this question is that it's all dependent on the procedure codes that you're billing. And if those procedure codes are part of Medicare reimbursement, then Medicare potentially could accept. So really, it's the procedure code that you're billing. Is it a license type for those providers that are billing those claims that will allow those claims to be reimbursed? So there are a few factors that go into it. I think a little bit more information would help to get a more concrete answer. But certainly a lot of factors that go into this one in particular.
Okay, next question is a part 2. Andrew sends in, can you bill case management when you are billing behavioral health day code H2020 when the case management occurs after the end time of the day code? An example of this is a time range for H2020 is 9 a.m. to 3 p.m. and the case management occurs at 5 p.m.
Yeah, so I think with both of these questions, Andrew, that you asked, these are coding specific questions. And we have coding experts here on our team that could certainly address these and provide the best information to you around the utilization of these codes and when it's appropriate to bill certain codes what. So Renee put out that poll about a consultation. I think this would be a great opportunity for potentially one of our coding specialists to step in and provide that answer to you.
All right, Andrew, we'll connect with you directly to make sure that you get your answers. Next question that I have is from Glenda. In the case where a client doesn't pay their deductible and we end up writing that off, does the insurance company get notified? Do they care?
Hey, Glenda, great question. They do not get notified if anything gets written off. Do they care? That's tough to say. My experience is once the insurance processes the claim, then they move on. Certainly if it's going to a deductible, the responsibility then is on your organization to collect. And I think there's an expectation from the insurance company that they do collect, but I haven't encountered situations where, they're coming in and auditing your payments based on the claims that are being processed. That's not to say that it can't happen. I've just never seen it.
All right. We have another question from an anonymous attendee. Does the timely filing deadline only appear to the first submission for the claim? For example, if they deny the claim and we resubmit it later, are we still okay if the date of the resubmission is past the timely filing deadline? Or does this vary from one health plan to another? Do they usually have a separate deadline associated with denials?
Great question. So a lot to unpack here. So timely filing applies to the initial submission as well as the resubmission of a claim. So it's possible that you could submit a claim, it gets denied, and then you resubmit it after the timely filing, and it'll get denied for timely filing again. And then in that case, you have to go through an appeal process in order to get that claim paid. There are insurance companies, though, where if we submit a claim and that claim gets denied and then we resubmit it after the timely filing, they're going to pay or process the claim. So it does vary based on the insurances. One thing that you can always do is you can submit a corrected or amended claim. When you do that resubmission, the initial claim, when it comes back from the insurance company, will have a unique claim number. And if you resubmit the claim with that unique claim number, it references back to that claim that you submitted initially within that timely filing deadline. So that's a way sometimes to get claims outside of the timely filing deadline through if the insurance company is going to pay. But there's a lot of factors. There's not a one-size-fits-all approach. Some insurers are more lenient than others. But one as far as the timeline is concerned, the 1 year mark is really important because once we get beyond 1 year, the odds of getting a denied claim paid they drop pretty significantly. So if you got to get your follow-up in, you got to get your claim submitted, make sure in almost all cases it's within a 1 year mark. But that's a great question.
All right, and I just want to address something that was also asked by an anonymous attendee, and that is are there CEUs attached to this particular webinar? For today's webinar, we do not offer CEUs, but stay tuned. We are getting ready to launch a CEU series at no charge to those of you who are in our database. We want to offer it to as many providers as we can. So when we send out that invitation, please feel free to share it. We thought this would be a helpful way for Symmetry to help you. We know how important CEUs are, and we also know that they're a pain to make time for, especially if you have to travel, and if there's a fee associated. So these CEU webinars that will be upcoming in the next couple of months is when it will launch. They are at no charge and all done virtually, so stay tuned for that. Next question is from David. Hours are based also on number of claims. My company has 25 clinicians. I'm not sure of the question attached to that.
I think that might have been referring back to the poll that we asked in the beginning. So maybe that was just a clarification.
Gotcha. I understand. Thanks, Justin. Okay. Erica sends, can you tell us about what the AR report is and how we can track this?
Yeah, absolutely. So your AR report, AR standing for aging report, AR accounts receivable. So when you submit a claim, that claim is going to appear on your AR report as open until it gets processed by the insurance company. Then when it gets processed, we're going to apply an adjustment to it. That's what we talked about earlier, that difference between our charge amount and what our contracted rate is. And then we're going to apply an insurance payment if there is one, and we're going to apply a patient payment if there is one. If everything is reconciled properly, that claim will be reduced to 0 on your AR report. If it's not, then it indicates that maybe there's an insurance payment that's outstanding, maybe there's a patient payment that's outstanding. So having an AR report that it's up to date with all the claims you're submitting will allow you to look and say, okay, well, these claims are outstanding, I need to follow up on them, or I need to get them resolved so I can get paid. Many EHRs have AR reports that allow you to look at claims that are out there. So if you're using an EHR, depending on the one, certainly look into that AR report. But the AR report is a way for you to track your claims that you're submitting, and over time, determine what's still outstanding, what needs to be followed up on, or maybe just something that just needs to be closed out and moved on from, maybe written off. But it's an important part of managing the revenue cycle because it's going to allow you to make sure you're tracking all claims over time.
Okay. Next question, Glenda. Some of our claim payment processors charges a percentage of what the insurance is reimbursing us. Is there a way we can avoid that?
Yeah, so I'm thinking of gosh, not PaySpan, but I know the ones that you're referring to, Glenda. At least I think I do. Yeah, I don't think there's a way. Echo Health is one that charges. There's a few others that are out there. That's their fee that they charge, in order to, do direct deposit, if I'm understanding your question correctly. The only way to get away from that would be to revert back to paper checks. So if you want to stay on direct deposit, there's going to be that processing or origination fee that unfortunately does come into play sometimes.
Okay. Next question. Can you bill a private insurance for unlicensed therapist under supervisor? So can you bill private insurance? Okay, go ahead, Justin.
Yeah, this is a question we get a lot. My suggestion would be go to your insurance company, ask them directly what their policies are. Certain insurance companies have come out and said, yes, we allow this policy, and certain insurances do not. It depends on the state you're in. It depends on where you're billing to. But if you go back to your insurance company, whether it's an email address or you have a provider relations rep, ask them specifically, get it in writing, and they'll be able to provide that guidance to you.
Excellent. Next question. Would you speak to the contracting process after credentialing is completed?
Yeah, so just generally speaking, we go through credentialing. That's when the insurance companies are checking the credentials of providers. They're checking education, work history, all those different things. And then we get to the contract. And so the contract can be as simple as they send us a contract, we fill out the information that's in there, you sign it, and then we just wait for the insurance company to sign it on their end, and then we're good to go. There might be actual contracts in other cases that we have to complete a whole bunch of information on. Again, with each insurance company, it's different. If you have an organization that you are trying to go and network with an insurance company for the first time, you'll need to get a contract with that insurance company for your organization. And in most cases, we see the contracting part of the process take longer than the credentialing part of the process. So I mentioned 90 to 120 days before. Part of that will be devoted to the contract. And it could just be as simple as, hey, we're waiting for the insurance company to respond back to us. Our team here, our credentialing team here does a great job of following up on those outstanding credentialing matters, making sure that those contracts are being responded to and the insurance companies are signing off on them when we need to. So it's something that we look to try and push along as quickly as possible. But making sure we have that contract tells us what our rates are and our effective date, very important part of the process, and usually happens towards the end.
All right. Next question is from a current customer of Symmetry. In regard to the timely filing of claims and denied claims, does Symmetry automatically file corrected claims?
Great question. We do file corrected claims for the specific, depending on the specific way that you do billing with us, because we have a few different ways. We can bill through your EHR, we can do billing via census or another way. I would recommend reaching out to your ASR and asking them, and they'll be able to give you the specifics based on the way that you bill with us or we bill for you. But excellent question, and thank you very much. We appreciate having our clients on the call.
Okay, couple more questions here. Why are the VOBs that are verified by our billing vendor or on the portals, i.e. Availity, so often incorrect?
Excellent question. So I'm not sure who the billing vendor is, but what I will say is mental health benefits are complicated. They're not considered medical. They're kind of like a hybrid benefit, right? They're not medical, they're not specialty, they're like kind of in the middle, they're a hybrid benefit. And so we need to make sure that we are verifying specific to mental health. And if you're working with a vendor that is not, specializing in behavioral health, like we are here at Symmetry, they may get those benefits wrong because they may not be looking at the right thing. Your specific service that you're offering might be subject to a copay when other services that same patient may offer, the deductible might apply, or vice versa. So having a vendor that is knowledgeable and has an expertise in behavioral health is going to go a long way to making sure that those benefits are accurate. But at the end of the day, behavioral health billing and benefits are complex. And so there are going to be times where there are benefits that are incorrect. It goes back to the reconciliation process, that fourth pillar that we talked about, as a quality check on those benefits, but certainly minimizing those incorrect benefits is key. And if you're experiencing a lot of them, potentially interviewing another vendor could be a way to go.
Excellent. And I think last but not least, we have more of a comment on an earlier question. For out of pocket, the patient pays us directly or the insurance policy for the allowed amount. I'm not sure if you remember.
The patient is going to pay you. So anytime they're paying out of pocket, whether it's a deductible or a copay or coinsurance, you will want to collect that from your patient. And so that goes back to the verifications that we talked about, getting an estimate of patient costs. So this way you can say to your patient, okay, you owe us $20. That's your copay per session. Then that becomes the out-of-pocket expense that you would collect on an ongoing basis. The insurance company will pay the difference between your copay, coinsurance, and your contracted rate. So again, if we have a $100 contracted rate and a $20 copay, you collect that $20 out-of-pocket expense from your patient, and then the insurance company will pay you the difference, or $80. So collecting out-of-pocket expenses is the way to go. Knowing what those are, providing that estimate, key to the success of a revenue cycle, and certainly, collecting those copays from your patients is the way to maximize your reimbursement.
Okay, we have one more question, and then we are going to wrap this up. Last question. I remember you mentioning mental health care out as a third-party payer. Do they cover substance abuse?
Again, just like the question, I think that was from William earlier, we will depend on the CPT code, will depend on the license type of the provider. So it will vary on a case-by-case basis. So if it's just a regular substance abuse, in my experience, yes, carve-outs will cover those services. There may be cases, depending on the level of care, that an authorization is required. But certainly, depending on the type of service that you're offering, is something that would determine if those services would be covered. And if you're working with a company like ours, we can help make sure that you are billing for codes that you would be reimbursed for. So if you haven't, signed up for a consultation with one of our specialists, I definitely encourage you to do so, so we can get all those questions as well as any others answered. And I know we're running up against time here. I just want to say thank you to everyone for spending your lunch hour, if it is your lunch hour, with us. Appreciate the opportunity to present, and certainly look forward to doing this again if we have another opportunity. Thanks, Renee. I'll kick it back to you.
Thank you, Justin. Just as a final note, if you did not participate in the poll earlier about wanting a consultation and you have since decided that you do, you can still be connected with one of our billing specialists by sending a direct email to renee.rosso@symmetryhc.com. I dropped that email address in the chat. I will also include it in the follow-up email when we send out this recording and these slides. And so please reach out to me directly. I will connect you with the billing specialist, and we'll be able to make sure that your questions are answered. And I just want to reiterate, Andrew, we know you had some questions earlier. We are going to go ahead and connect you with a billing specialist that can make sure that you have the right answer for that. So again, as Justin said, thanks everybody for coming today. We really appreciate the opportunity to share information with you. We are going to be launching a part 2 of this series at some point soon. So look out for that invitation, and look out for an invitation to our CEU webinars that will be lasting every few months for the rest of the year. And so if you have any questions, reach out to us. Otherwise, we look forward to supporting you and sharing more information in the upcoming months. Anything else, Justin?
No, I'm good. Thank you so much.
Thanks, everybody. Have a great day.
Bye, everyone. Thank you.